Hello, this is Dr. Bhomik. Welcome to another edition of my lectures. Those who are following my lectures by now, you know my introduction, so I will not go there anymore. And today, I'm going to talk to you a very interesting subject, and this is also a very favorite pediatric board question. What we are going to discuss today is the rickets, vitamin D, and parathyroid hormone. I will modify my discussion to make sure that you know all the things that comes in your test, and keeping that in mind, let's go ahead and get started. Before we go to any discussion of rickets, there are two things that we need to know, actually three things that we need to understand a little bit. The first one is parathyroid hormone, the second one is vitamin D, and third one is a little bit about calcium. So we know that parathyroid hormone is a long chain amino acid. Actually, it is even inside the parathyroid gland where it begin to get synthesis, like in rough endoplasmic reticulum, and it is about 115 chain amino acid. Then by the time it is released to the circulation, is intact form of parathyroid is 84 amino acid. So when it is released to the circulation, it's released in three forms: intact forms, which is about 50%, and then the carboxy terminal and the mid region and amino terminal. Now, the amino terminal has 34 amino acid, is the first 34 amino acid of this big chain, and that's the active form. However, when somebody measured the parathyroid hormone, order a parathyroid PTH test, we usually measure the intact form because that's almost 50%. So that is the one that we measure. Amino terminal is hardly ever used unless the patient has kidney disease or some form of problem with the other related to the other enzyme deficiency. Okay. So the most important stimulus for the synthesis of parathyroid hormone is the calcium. So calcium is primarily responsible for synthesis and secretion of parathyroid hormone. Magnesium is also very important because magnesium, although is not responsible for the synthesis, but it is responsible for the release of parathyroid hormone from parathyroid gland. So it mostly affects the secretion and the release, but it is not important for the synthesis. And 125 hydroxy vitamin D may also play some role. So when the PTH is released to the circulation, and it has three target organs: bone, GI tract, and kidney. So in response to the parathyroid, it is interesting to know that the net effect and the action of this intestine and bone is quite different. So in bone, it reabsorbs calcium from the rapid exchangeable pool, and so it releases both calcium and phosphorus. So it both goes up. From intestine, it increases the calcium absorbing protein called calmodin, and it helps in absorb the calcium from GI tract And as you know, that absorption of phosphate is passive. So once the calcium is absorbed, that's the active process, energy generated and phosphate just go through. So, so let's see in the bone and intestine, the effect of parathyroid is positive for both calcium and the phosphate. However, the kidney is the final determining organ. Coming to the kidney, it absorbs the phosphate, but it absorbs the calcium and dump the phosphate. So there is a significant phosphaturia, but the net effect is what kidney decide. So in response to the parathyroid hormone, the net effect is increased calcium, decreased phosphorus. So this is a very important slide in terms of synthesis of vitamin D. And I like to go through this one a little bit more elaborate, but you really don't have to know anything more than what is it in the slide. So let's see. We do know the source of vitamin D is from food and is also from skin. 7-dehydrocholesterol, with the effect of ultraviolet radiation, and that's a provitamin D, and that goes to the liver. And from the diet, both vegetable and meat contain vitamin D. If it is coming from the vegetable, we call argocalciferol, argo means plant, and from the meat we call cholecalciferol. So this is, but it really doesn't matter. So both from diet and from the skin, it really become vitamin D3, which is this is not an active form. It has to go to the liver then. So it goes to the liver. So how it goes to the liver? From the dietary sources, from right here, it goes to the liver binding with chylomicron, because vitamin D is a fat soluble vitamin. And however, from the skin, they have to come to the liver also, but they come binding with vitamin D binding protein. So the final common path for both of them is the liver. The liver there is a very important enzyme there in the liver, which is 25-hydroxylase, and they convert D3 to 25-hydroxyvitamin D3, or called calcidiol. 25-hydroxyvitamin D3, which is called calcidiol, and that's not active form. This is not active form. However, when you measure the vitamin D level in the blood, we measure the calcidiol, 25-hydroxyvitamin D3. Now let's come to the real place, is the kidney. Now the kidney, there is an enzyme called 1-alpha-hydroxylase, and that enzyme synthesis depends upon the parathyroid hormone. So PTH dependent enzyme 1-alpha-hydroxylase in the kidney convert the calcidiol, or 25-hydroxyvitamin D3, to 125-hydroxyvitamin D3, which we call calcitriol, and that's the active form. So we need this one for the function of vitamin D. Now let's go to the action of vitamin D. Well, it increases the absorption of calcium via active transport. So absorption of calcium is active transport. And it's also increased the binding protein which absorbs the calcium from the brush border of intestine. So it also helps to absorb phosphate, but only by passive way. That means the force that's generated because of the active transport, and the phosphate is kind of opportunist and get through. And so it absorption of the phosphate is passive. And the action of vitamin D on GI tract does not depend too much on PTH. So it is not that much of PTH dependent. The vitamin D action on the bone. The bone, you know that the bone mostly, very small fraction is probably less than 1% is the rapid exchangeable pool. This is the one, is kind of checking account. You can withdraw from them very quickly and take care of the hypocalcemia or hypophosphatemia or so forth. And that when PTH works at the level of the bone, it actually do increase both absorption of calcium and phosphate, and so it comes from rapid exchangeable pool. Okay, so vitamin D deficiency, that's what we will be interested and going to talk about it, is result in rickets in children when they are growing and osteomalacia or softening of the bone in adult. So now let's come back and see what is rickets. What does happen and what is the pathophysiology of the rickets? Pathophysiology is, it is the undermineralization. Basically, it is the undermineralization of epiphyseal growth plate. It is a disease of the childhood when the bone is growing, and if vitamin D deficiency occurs in adult, it makes the bone soft, what we call osteomalacia. However, when there is a vitamin D deficiency in children, there is both osteomalacia and undermineralization. So they have, that's actually double whammy in children. Okay. The long bones and the growth plate are affected. So for your exam, you see the vitamin D deficiency ricket. There are two other kind of rickets, which is very rare, but it's sometimes comes in your examination, and that's called vitamin D dependent rickets. It actually kind of misnomer. And vitamin D dependent rickets again divided in two categories, type 1 or type 2. This is also known as PEDR type 1 and PEDR type 2. And familial hypophosphatemic rickets, and this ricket is usually X-linked, but we'll talk a little bit about that and just what you need to know for the purpose of your exam. And hypophosphatic ricket is probably in this country more common than vitamin D deficiency rickets. So let's see vitamin D deficiency. When does it occur? In infant and children. Primarily when the baby is breastfed without any vitamin D supplement. Breastfed without vitamin D supplement and nutritional deprivation. Obviously, the growing developing country or underdeveloped country, nutrition is a big problem, and overcooking also destroy the vitamin D. So nutritional deprivation comes various way. And then another, lack of sunlight exposure. Now this is important. So a lack of sunlight exposure is not same for everybody. Let me give you an example. This study done long time ago in MIT, and they clearly documented that exposure to the sun and the formation of vitamin D is not same for everybody. For example, if a Caucasian person with fair skin goes to a beach and exposes himself for sunlight for about an hour, the amount of vitamin D that this person will make in an hour, it will take almost 2 hours for a brown color skin Asian American, and about 3 to 4 times more for African American. So that's why vitamin D deficiency, ricket, is mostly seen in African American babies, and especially if they're breastfed and if they are not supplemented with vitamin D. And with that, let me go to the next one. The clinical finding of vitamin D. Most important that you've got to remember in the first year of life is the failure to thrive. And that's the people forget about this one, but the failure to thrive is a very common presentation in the first year of life. Then bone pain. These babies are always crying, and once somebody wants to hold them or pick them up, they will cry a lot because they are in pain, and that's because of the periosteal reaction. Periosteal reaction, and there is also myopathy, and in fact sometimes it has been misdiagnosed as upper motor neuron disease. And the bony changes, and that we will discuss in our next slides. Okay, this is a case in late 90s. We published from Air Force Medical Center at Keesler and University of South Alabama, Dr. Rickets and myself, and we published 3 reports in AJDC, American Journal Disease of the Children. I don't think that journal is there anymore. And here, this was the one of the most important case studies that sometimes can help, where the 3 patients with African American entirely breastfed, they presented with a failure to thrive. And then the diagnosis was made and started on vitamin D, and as you can see, the weight gain and the baby also the height, length increment. So this is actually one of our study was one of the big factor in making the American Academy of Pediatrics to recommend routine supplementation of vitamin D in breastfed infant. Okay. And so this is very, very important slide. So bony changes in the rickets, because I have some x-rays that I will show you. The cupping and widening and the flaring of epiphysis. There is very little of any disease that you would know will do that. So cupping, widening and flaring of the epiphysis. In infancy, if it is severe vitamin D deficiency, you get the prominent of the frontal bone, that called frontal bossing. And one will also see the expansion of costochondral junction, and the form, in severe form, they form a right sulcus, they call pigeon-shaped chest and Harrison sulcus. Pigeon-shaped chest and Harrison sulcus. And there is a periarticular swelling. If you look carefully, their ankle, wrist and the knees are expanded, looks big. And in fact, sometimes they have, because of the pain, full joint, sometimes they have misdiagnosed as juvenile form of arthritis or some other joint problem. This is important. I want you to remember that the bowing of the leg only occurs when they start walking or supporting their weight. Now, in exam, sometimes they try to fool you. They might give you a 6 month or 5 months old baby who has the bowing of the leg. That's not ricket. That could be a positional inside the uterus, how it was, or some other bone disease, but that's not ricket. Only bowing of the leg will be seen when the baby and the child is walking or supporting the weight. Now, this is a patient of mine came to see me because of the severe pain here in the wrist, and actually pediatrician thought that this could be some form of juvenile arthritis, and this patient indeed have vitamin D deficiency ricket. And this is another patient that again, you see this is African American baby, that this is a 18 months old. By the time I saw there is a significant bowing of the leg. Significant bowing of the leg. And I just want to tell you that I submitted this patient and also the x-rays, many x-rays to the American Board of Pediatrics, and they were accepted. So that's in your data bank. Actually, many of my previous residents, they said in our examination that either the test examination or really board examination, they saw this x-ray. So please pay attention to this one, because this is one of the classic. And here is that, let's see the cupping of the bone, cupping here, and this flaring of the joint, expansion of the lower end and the cupping. This is a very classical X-ray of rickets. There is very few conditions that I know of will make this kind of change. Sometimes congenital syphilis might get confused, or multiple epiphyseal dysplasia called MED, very rare, and they also point the dysgenesis of epiphysis. But for your purpose, if you see the cupping, there is only one diagnosis, is vitamin D deficiency rickets. However, this will also be present in hypophosphatemic ricket. So this is the classical finding. Okay, and here is the bowing of the leg and actually demineralization of the whole bone, and it looks like a washerman's bone. That means it looks whitish, total demineralization, and this cupping and flaring, and look at this expansion of this lower end of the epiphysis. So this is a severe form of rickets. Okay, so I'm not going to go to that one very much, because most of the time the diagnosis is made in the second stage. In the first stage, low calcium, normal phosphate, alkaline phosphate is elevated, vitamin D is low, PTH is upper normal, and no body changes. Second stage is calcium is low or low normal. Now this is the phosphate diuresis, phosphate is low. Look at the alkaline phosphatase has gone up, and then vitamin D is low to low normal. And here, from here, you see the changes of X-ray changes, and this is the most advanced or fluoride form of rickets. And one thing I have to tell you, and please do remember that alkaline phosphatase is the most important biochemical finding in the rickets. If something looks like ricket, but you have a normal alkaline phosphatase, you cannot make the diagnosis. As you can see, all these stages, alkaline phosphatase will be elevated. So if you don't find alkaline phosphatase is elevated, look for other cause. Or partially treated ricket, it might confuse, but it is not, is very common. prevention of vitamin D deficiency. Now, different people are doing different way. Some people now give 800 units daily and 400 in children and 800. This one I'm not going to, I still keep the time honored 400 units for children and 800 units for the adult, but your attending or other endocrinologist may have a little different approach, so I'm not going to argue there that much, but this is some guideline. And obviously for treatment of the ricket, food rich in calcium, and sometimes depending upon the calcium level and vitamin D level, you would probably would like to keep some calcium for about 6 to 8 weeks, depending upon how the healing is occurring, depending upon how the biochemical changes are correcting, and so you can supplement, and that part I'm not going to address. And this, there are two approaches. One is continue to give 4 to 10,000 units of vitamin D daily, and then keep on checking the alkaline phosphatase and the other parameters, and depending upon that you adjust your dose. However, there are other groups, they give intravascular vitamin D, big dose, like a 50,000 units, and so that's another approach, but I personally prefer the oral supplement, oral administration. And then they should be followed carefully, and then don't overdo it. And once the rickets is healed, then reduce the dose of vitamin D to appropriate level. Now there are two rickets that I'm going to talk to you, and this comes in your test, those who are going to make probably more than 90th percentile. Now, vitamin D dependent ricket, PEDAR type 1. PEDAR type 1 is autosomal recessive, and basically this patient has deficiency of enzyme 1 alpha hydroxylase. Therefore, they do not convert 25 hydroxyvitamin D to 125 hydroxyvitamin D. So when you do the blood test, what you are going to find is 25 hydroxyvitamin D level is very low, but 25 hydroxyvitamin D is high to upper normal. So that means it's not being converted. I put a star mark because that's the biochemical hallmark of making these diagnoses. And once you start treating them with the active form of vitamin D, then there will be improvement of the rickets and they will get better. However, PEDAR type 2 is a difficult one because it is also autosomal recessive. This is a receptor defect, end organ resistant. So therefore, there is no absorption of calcium, and so this is a resistant defect, and it is associated with alopecia areata or totalis, and there may be the other hormone deficiency like thyroxine deficiency, resistant to thyroxine, T4 resistance syndrome, testosterone resistance syndrome, cortisol resistance syndrome, but they are associated with alopecia. Not all cases, but it's one of the characteristic finding that you can see in some patient. I'm going to talk a little bit about the hypophosphatemia rickets. This is X-linked hypophosphatemia rickets. However, many endocrinologists will tell you that it could be autosomal dominant, and when it affects the female, they are more severe. But in general, for your purpose, this is X-linked hypophosphatemia rickets. So the problem here is the renal tubular transport and absorption of phosphate. Defect in transport and also defect in absorption. And this is due to the mutation of PAX gene, PAX, PACS PAX gene, which is the phosphate regulating endopeptide gene and is located in X short arm of the X chromosome 22.1. So this is X-linked. And as a result of this, there is an increase in fibroblast growth factor 23, and it inhibits the reabsorption of phosphate and decrease 1-alpha hydroxylase synthesis. There is one thing I did not mention, that for formation of active form of vitamin D, you need PTH and also the appropriate or optimum concentration of intracellular phosphate. And since the phosphate cannot be absorbed here, or phosphate diuresis, eventually there will be lack of phosphate in intracellular. And as a result of that, when you start treating them, you really have to give these active form of vitamin D. So this is the X-ray of a vitamin with a phosphate-resistant ricket or X-linked hypophosphatemic rickets. And here is also the bowing is pretty much same. This happens to be Caucasian boy, and so this again the bowing of the leg. In this patient, usually in familial hypophosphatemic rickets, the changes, the bowing of the leg is more prominent, but like expansion of the wrist and all other that I have described in the vitamin D deficiency ricket is not prevalent. So how do you treat them? Lab finding is going to be normal calcium, very low phosphate, but there will be high alkaline phosphate. As you can see, this is synonyms with the rickets. ALP is high. There will be normal 25 hydroxyvitamin D and normal to upper normal parathyroid hormone. So how do you treat? You have to give a lot of oral phosphate, and there are a lot of new form of phosphate, and the other medicine has come to help them out. But before wish to keep phosphate, you have to give every 4 hours or so. It's really very difficult for the patient to take. And you have also going to supplement 125 hydroxyvitamin D, and this is X-linked. Okay, so the other form of rickets, like with renal tubular acidosis, renal osteodystrophy, all these things are usually mostly disease of the adult people, and you will not be bothered with that. Okay. Thank you very much.